This is nursing care during a pediatric emergency. So what are we looking at? Why do kids have an emergency? It's almost always going to be a respiratory arrest first. And with adults, that's not true, right? They have that MI first. So why do kids get a respiratory arrest? Well, their airways are so much smaller, it doesn't take very much to plug them off. And they don't have as developed of immune systems. And a lot of times this respiratory issue is an infection, and all that mucus plugs up their airway. Things like near drownings, which we're now calling submersion injuries, that happens because, well, they're not as coordinated and they fall in water. They don't know how to swim. They can't swim with clothing on, even if they could in, last summer. Or toddlers fall in. They have that big head that's heavy and pulls them over, and it's hard for them to get back out. Choking, right? This happens with kids, small objects, and we're most concerned about things that are the size and shape of their airway. So hot dogs are notorious because kids are eating them as they're running around and playing, and so they're yelling and eating at the same time. That hot dog totally occludes the airway. Other things that are, marbles, things that are the shape of the airway are a real problem. Latex balloons are a real problem, which is why at Valley Children's they only allow Mylar balloons. And then sudden infant death syndrome. So when we do have that medical emergency, if you just kind of remember, there are some medications we can give. If we can't get vascular access, but the child's been intubated, there are some things we can give through that endotracheal tube. We can give lidocaine, epinephrine, atropine, and then naloxone, which, if you remember, that's our antidote for a narcotic. So that's for in an overdose situation. So nursing management of a child in a pediatric emergency. We're going to do the ABCs. And I know in CPR with adults, they're starting to say CAB to start chest compressions early, but kids are almost always respiratory arrest first. So we still stick with that ABC. So maintain a patent airway. Give them some breaths, provide oxygen, and then assist in ventilating, give them breaths, and then we're going to assess for circulation. Small children, infants really don't, it's hard to get a good carotid pulse because they don't have much of a neck, and they have such a tiny radial pulse. Our best one is brachial. Then administer rescue breaths or CPR as needed. Watch for changes in status. Are they improving? Are they deteriorating? And then offer support to the family and the child if they're conscious. When you open that airway on a child, it's really important to open it the right amount. If you just lay a child flat and their chin kind of comes down, you can see that top picture. Their tongue, their jaw goes back and blocks their airway. We want an infant in the sniffing position. So like they're smelling something nice. Their nose should be pointing straight up at the ceiling, and that's going to open that airway the best. If you hyperextend them, it actually makes the airway smaller, right? You're taking that airway and kind of stretching and bending it, which is going to make it a little bit smaller. If there's concern of cervical spinal injury, we can do the jaw thrust. So there are a number of different airway devices. You'll see those anesthesia bags used by physicians and respiratory therapists. Usually nurses are not trained in using those. They're the ones that are just sort of a floppy gray bag. You plug it in, you have to actually let it fill up before you can use it. They have much more control, but you can also do damage to the child. You can give too big of a breath, cause a pneumothorax if you don't know how to use it. So don't use it if you don't know how. Instead, use the bag valve mask, or I usually I'm used to this being called an ambu bag. It's also called a manual resuscitator often. And that, it stays full. And when you squeeze it, if you're, all that adrenaline's going in you too, and you're squeezing it too hard, it's got kind of a pop-off valve and won't let you overventilate and cause a pneumothorax. A laryngeal mask, as it sounds like, it goes down into the larynx. Oral pharyngeal or nasal pharyngeal, again, goes into into the airway, but not all the way down into the trachea, which makes it easier to insert. And then our best for doing our best ventilation is a tracheal tube. This, you've got to be trained in doing it. You've got to see the epiglottis and slide the tube into the trachea. Can go oral or nasal, so we usually call it endo or nasal tracheal tube, ET tube. We need vascular access in an emergency. If we can get a peripheral IV, great, but kids are going to shut down circulation to the periphery, so it's hard to get that, which means it may need to be a central line, and that has to be started by a physician. Jugular, femoral in the groin, subclavian right below the clavicle. A physician does a cut down, which is to make a little cut in the skin, and then it's a regular IV catheter, but they see the vein as they insert it into the vein. And usually they'll put a stitch there to hold it in place. So the saphenous is on the inside of the ankle, but really they could do a cut down on any vein the physician feels like they can get to. Interosseous. This is a great IV site in an emergency. In an emergency, we've got to give a lot of fluid, right? We've got a blood pressure that's dropping, and we're trying to increase volume. This goes into the bone marrow, where it's then goes into the bloodstream. We can put a lot of volume fast. The spot we use on kids is the top of the tibia, right? So this is a lower leg just below the knee. There's a nice flat spot here. It's kind of a little gun that shoots that in, and then you can see you take the needle part out and hook it up. So ABCs of life support, as we said, airway, breathing, circulation. And then after those, you should do the secondary survey, which is D&E, disability, which means assess the level of consciousness. What's going on with your child? Are they alert? Are they not? Exposure. What's there at the scene? What's happening? And could this be an exposure to a substance for the child? Our neurologic assessment of a child during a pediatric emergency, we want to be assessing their level of consciousness. In an infant, they're not going to answer questions about their name and where they're at, but are they looking around? Are they taking an interest in the environment around them? Look at the child's head. Assess those eyes, the pupils, what's happening. Look at their face. Have we had trauma to the head or the face? Look at their movement. Are they moving spontaneously or not? And if not, we need to do that pediatric or do a Glasgow Coma Scale. And there is a pediatric version of that. So on an older child, we use the same Glasgow Coma Scale. And if you remember, it's 4, 6, 5, total of 15, minimum of 3. 4 is eye-opening spontaneously, and that's the same regardless of the age. The motor response, and this is the one that has up to 6, it's a little different for an infant because they can't obey a command. So we're just looking at, do they move spontaneously? And then verbal, we've got quite a few differences because they can't have the oriented verbal responses because they don't talk. So we've divided that up. Things that are appropriate by age for an infant or a child, or then a child 5 or above. But no matter what, our minimum is 3, our maximum is 15. Shock. So what is shock? Shock means we have not enough blood flow to meet the oxygen and metabolic demand of the body. We talk about compensated shock, means the blood pressure is still normal, and decompensated shock is when the blood pressure drops. Remember, kids are amazing at compensating. They can clamp down all those capillaries, raise their systemic vascular resistance to maintain their blood pressure until they can't. And when they can't, they crash fast. So in shock, the things we're worried about is a decreased cardiac output or an impaired systemic vascular resistance, or both. And I'm saying kids, even when they have decreased blood volume, they can maintain their blood pressure for a while, and then when they can't, and sometimes in like septic shock, the toxins will open all the capillaries, so now we have the same amount of blood and way more volume for it to circulate through, which makes the blood pressure crash. So anyway, there's different ways this can happen. Remember, in pediatrics, when we're talking about cardiac output, it is rate dependent. In adults, we talk about stroke volume, right? An adult can make their heart go just fill more full and give a bigger, fuller, harder beat. Kids don't do that. They just beat the same, and if they start having not enough output, they beat faster. They don't necessarily change the stroke volume. So what are we going to see on a child with shock? The early signs, right, because blood pressure is a late sign. Early signs, pallor. They're going to circulate to the vital organs, not to the skin. So we're going to see paleness, circumoral, around the eyes. The hands and the feet are going to be cool, pale, delayed capillary refill. Weak peripheral pulses, your central pulses are going to be a lot stronger. This is going to lead to respiratory distress, brady or tachy dysrhythmias. They might start out tachy, trying to compensate, and then when they can no longer compensate, you see bradycardia and hypotension. So what are the emergencies we see in kids? Most of the time, a respiratory arrest. Another thing that happens is shock. This can be from blood loss in an accident or septic shock from an infectious agent. We can get cardiac arrhythmias and cardiac arrest near drownings. Again, we're starting to call this submersion injuries. Poisoning, they get into something, and then traumatic injury. So what's the kind of respiratory patterns you're going to see? Probably initially tachypnea, to increase the rate, trying to get rid of excess CO2 because they're not getting rid of those acidic waste products that build up. That then turns to hypoventilation, which is a decreased rate and depth. So when we listen to the lungs, we're going to hear less. The sounds will be decreased. Okay, this is starting to get bad. You can get periodic breathing where they have those breaks, those lapses of breathing, and we'll probably see increased work of breathing, that they're using those accessory muscles. So what causes cardiac arrest in children? And I'm going to say usually, most often, it's a respiratory arrest. The heart muscle gets ischemic enough that then we develop a cardiac arrest. But a true cardiac arrest that just happens on its own can happen from an electrolyte imbalance or a drug ingestion. They get into, grandma's cardiac medicine and they think it's candy and take it. It can be from a heart defect, congenital heart defect they're born with, acquired. It's something that happened after birth. They do sometimes have potentially lethal arrhythmias, such as our prolonged QT syndrome, either overdevelopment or underdevelopment of the heart, right? So cardiac hypertrophy or hypotrophic cardiomyopathy. And then traumatic injury to the chest, doing damage to the heart or the major vessels.